as you've all heard, AI becomes more and more important in our lives. And you can write your patient reports now with ChatGPT. But it has a long history. It's nothing new. It's just that our processing power of the computers has just increased so much that these old theories here can now be applied in a large scale. And so those neuronal networks have been around for quite some time. Like the perceptron network is from 1958. That's one that's used nowadays, but just with different computers. We use them for drug discovery. It's already applied for drug discovery in a big time. So with AI, you can find associations in the genome, in the effects that the drugs have, that is way more powerful. AI is always good when you have lots of data, lots of variables, but it's really bad in making a common sense out of this. But it can show you hints and pieces of where the correlations are. But whatever it means, like a deep learning strategy that would also develop itself a meaning to the data, is sometimes not, most of the times not possible. Only in very restrictive data spaces where the data is very well organized and very clearly organized. Because with neuronal networks, if you put garbage in, you get garbage out. So there is no intelligence inside that can judge the quality of the data, about the quality of the data. And the quality of the data is the most important thing and the thing that we're struggling the most in the healthcare system. Because as you all know, the patient reports and how data are stored in a hospital is different from hospital to hospital, from site to site. And so making sense out of this is not an easy thing. That's a perceptron network that you see here. And that's a deep learning network. So there are more layers of decision in between. That's the input, that's the output. And the more layers you have, the less you can predict what a model like this does. So it's a black box. We don't really know how the algorithm is put together. It's just there. And that is a big problem when it comes to responsibility for decisions. Because we can hardly say, well, it was my decision if a network has made the decision, because we don't know what the network does. And on the other hand, we can hardly say it was the network's decisions if we are not capable of looking into the network. So transparency in how AI works is very important and getting more and more up the scale of importance in development. So deep learning works like this, and machine learning, you still have the doctor that says, well, this makes sense, this makes no sense, and so on. You understand the difference? Like, if a deep learning mechanism would look at us here, and we just want him to distinguish male and female, and then we figure out that it actually looks at the images up here, and makes the decision based on these images. It says there's more girls in here than boys, which is true because there's only girls on the walls. This could be a false determination, but you don't know because it was correct, but it has looked at a different thing. And in this case, we would tell them, don't look at the walls, you need to look at the faces here. And then it knows, okay, don't look at this, but look at the faces in here. So this is making sense out of data. And so this is the more common way, and it's the way that we still, in a larger scale AI approach, we will stay with this for a long time because data are not good. And so working very hard currently in Europe to get a good databases for more approaches like that. This is one of these networks where you can see that they do work quite well. What's disturbing is that these are doctors here and that's the network. And you've all heard that in radiology that these networks actually work better than the doctors. They see more details, they get the more accurate diagnosis, but it's just for a very small task, for a very specific small task, and not for the whole picture. And that is the difference, because these people, they have a lot more additional information. You know, they don't just look at an image, but they look at patient history. They actually have talked to the patient, do you have pain, and so on, you know. So we have a lot more variables that we can integrate, but not with the high accuracy. So when you look here at fundus exams, there are different networks, and there are also ophthalmologists and optometrists, and the really bad thing for us is that the optometrists perform better than the ophthalmologists. Must be a mistake. Well, no, depends on where this study has been done. In the US, the optometrists are really well-educated academics. You know, it's a very similar curriculum they have as the doctors. And so why not, shouldn't be they more capable of doing anything better than us? Of course, in Austria this wouldn't be the case, because doctors have an academic education, you know, and see patients, and optometrists make glasses. There is no clinical aspect to this. So like in perimetric glaucoma, these algorithms work really well. You can very nicely see, you know, when we define how a visual defect evolves, you have this one center point, and then additional two around will evolve. Then you have a p-value above 0.05 for this being an exacerbation of the visual field. And finding these spots where this is the case can be nicely done by an algorithm. So that's very helpful, that it points out areas of progression, but still we need to tell it, is this progression or not? And as you know, the vast research of the Canadian groups on progression, like Bell, John, it's very hard to tell whether there is progression or not, even for the most experienced people with large databases. So the perimetric, there are different ways of algorithms where you can look at perimetric changes, and you can see that they perform fairly similar. The wide field fundus imaging is now a tool that we have where we can get lots of information, lots of data for these networks. And this changes the rules a little bit, because there is a possibility, like in Salzburg, we are currently establishing a telemedicine network between the doctors in private practice and the clinics, where they send in situations of retinal patients with retinal diseases, and they send in one of these wide field images and an OCT. And having these two informations, you can very nicely, in 50% of the patients roughly, you can tell what it is and what the doctor should do with the patient. Because otherwise they refer these patients to the clinic, and maybe it's not even necessary. So we can get rid of 50% of the patients, at least that's what we hope. We don't know yet. But these wide field images, of course, deliver a lot of information. And so this would be the normal fundus image with the fundus camera. And there, the various algorithms from neural networks and artificial intelligence learning strategies are shown here, and you can see that the accuracy is quite high. So it's a good screening tool. it works rather well to show anomalies on these wide field fundus photos. There's even more databases, because if an artificial intelligence tool is trained with a certain population, then it can find the right problem or diagnosis in that population. But if you go to a different place with a different population, then those networks are completely useless. So they're only good if they have databases from different areas of the world that they can train their networks with. And currently the partner university of the Paracelsus in Salzburg is the Mayo Medical School with Mayo Clinic. And we are working on an exchange of databases currently, because of course the Mayo Clinic is very advanced in terms of AI research in medicine, but they don't have the patients, because their clinic is in rural Minnesota. There's basically no genetic variability. It's all the same population they have. And so they have one clinic in Arizona and they have one in Florida where they can get in additional data, but they don't have European variability in their databases. So it's something they need, otherwise their AI approaches will be useless in Europe. So these data sets are very important to get these trainings, but it's not always that they are really huge, you know. That's the number of images in here. It's not really big ones. So it's very important to increase these databases. That's for open-angle glaucoma. There is like assessing the progression, use the retinal nerve fiber layer and so on, fundoscopic images and so on. And there you can see the p-values of detection. And there are some really good ones that work really well. So we shouldn't be clueless of what's gonna happen in the near future. There will be very powerful instruments that will support us in our patient care, but there is currently no fear of doctors getting replaced by AI machines, so that's far away. So it will happen eventually, I'm sure, but not in the near future. That's going to take a long time because we have no databases. So this is one thing we did in Salzburg. It's a glaucoma risk calculator, if you want to. And we looked at 7,000 patients that we followed. It's a population-based sample of 7,000 people that we followed over 20 years. And we trained neural networks with this. And in this, we have a negative predictive value of 99.2%, which is really good, and a specificity of 100%. And what we can do is the following. We can tell roughly 66%, up to 75, but minimum 66% of the people that walk into the office, we can tell them that they will not get glaucoma within the next 10 years. Which means that 2/3 of the patients you can send back home after having that scan, and that reduces the workload tremendously. So 2/3 less patients that we need to look at with this. And we've published this in the year 2003, and it's been in place in the glaucoma outpatient department ever since. So this is really helpful for the doctors to make decisions. And then there is the possibility of combining models. So you can combine fundus photos with visual fields, which is a good thing. One would think, yeah, let's combine everything we have. It's getting better and better the more data we have. Well, that's not true, because all these methods have different detection sensitivities, and they not all do detect the same thing. If you have like a standard automatic perimetry, then a nerve fiber analysis and an optic nerve head imaging method like the HRP is a different form of visual field. In a sample, let's say, of 84 patients, the perimetry will detect 35 patients with a problem. The nerve fiber analysis will detect 35 patients with a problem. And the second visual field will also detect 35 patients. But the problem is that it's not the same patients they detect. The same patients is only 16, where all 3 of them agree. So if you have only the visual field, that one, then you can say, well, you have a problem. My visual field tells me that you have a defect. If you have that one also, your patient might be here, and the perimetry detects the problem, but the optic nerve head analysis doesn't. What do you tell the patient then? I have 2 instruments, I don't know. They don't agree, I'm sorry. Like, well, it's a problem. So the more instruments you have, you get into these troubles. And you can change the limits of agreement. And when you're very conservative, of 84 people, you know, they may shrink down that only 3 of them, where all these instruments agree, will, according to this, have glaucoma. So what is the problem of these instruments in general? They must not tell a patient who has glaucoma that the patient is healthy. That would be the worst case. So companies must design their instruments to not overlook a sick patient. And that means that they have to put in lots of false positive patients that don't have the disease, but just to make sure they don't overlook a patient that actually has glaucoma or whatever kind of disease. So you have false positive patients in large numbers. And if, like, the optometrists buys the instrument, you know, or even worse, let's say the pharmacy department buys the instrument, so they can already take the blood pressure, you know, in pharmacy, and they will have an OCT or whatever instrument there, and then they scan all these people because it's good, you know, to have lots of access points to the healthcare system. They will come up with lots and lots of false positive people. They will send to the hospitals, and they don't go to the eye doctors anymore. You know, they go to the, I don't know, to the bakery, because the baker has decided to buy an instrument, and then you can have your scan there. And so the centers will be just overwhelmed with false positive patients, and that's what we fear. And that's what we've seen with HRT, for instance. When I was in the States, HRE was big time diagnosis. And does anyone know HRT? Yeah, there are still some instruments around. So it gives you these nice crosses, you know, green checks and red crosses. And in the department in Harvard, we said, well, this is another one with red disease, because all the red crosses, you know. And those were mostly healthy patients that didn't have anything, but the machine just made sure that it doesn't overlook a patient and deliver the false positive. So that's a problem. So and there's lots of things that you can combine, IOP, visual field. When you put that into a machine, it gets really complicated. And we are not there at all, you know. We are at single variables, you know, single variables of OCT and so on. So the black box is the problem, as I mentioned before. We don't know what it does. And there's an example for this is a correct analysis of an AI network for glaucoma. It will find problems at and around the optic nerve head. This one here has found other problems, like here or like here. These are the pictures on the walls. You know, it looks at something that has nothing to do with glaucoma, but is a common denominator. And so we always need to look very carefully at the decisions these networks make, because they can look at very different things. And there was a nice study where they have looked at many countries in the world and how people would feel about diagnostics in different levels of the healthcare system. And maybe this is not the important one, but like that one, in general, the problem is seen at the lower levels of healthcare expertise. They have more fears of that neural networks will come into their field and make decisions which could be wrong or could replace them or whatever. The ophthalmologists at the top line of the expertise, they weren't so afraid about this. They don't see the problems so highly. But when you look at the fear of being replaced here, you can see that the ophthalmologists don't fear to be replaced at all. But it was mostly ophthalmologists who have been asked in this sample. So the fear is more at the lower levels of expertise or education or whatever you call it. But ophthalmologists have not a big fear to be being replaced by artificial intelligence. What's the meaning in here? It's so complicated. That's a good answer. When will doctors be replaced by artificial intelligence in terms of diagnosis, decision making, robotics, surgery? Never. Who thinks in 20 years from now? So you're young. What are you going to do in 20 years from now? Change profession. You can ask an AI what to do. So it's only two of you. So who thinks in 30 years, 40 years? That's when you retire, roughly. Yeah, well, we don't know, but I'm sure it will come one day. One day, no question.
Who is in charge of putting all data? Is it doctor or medical engineers or something?
It's a combination. It's something we need to learn, that engineers need to talk with doctors and vice versa. And Mayo Clinic has an educational program for bridge functions. So people who actually translate between these two entities. And it's mostly doctors that go into that education, not so much engineers. But it's always driven by the doctors. So doctors need to say what they need. And engineers can make it possible to happen. It's data mining is not the approach that people think can be successful. You know, just put in lots of data and let AIs figure out what's going on. That's fantasies from the past. This doesn't work. But as soon as we get really good databases, and there is an initiative of the European Union. So first was the data protection initiative by the EU, and now it's the common data health data space initiative, where we try to put together all these remote databases and make sense out of them and put them into one big construct. So this, you can imagine this is going to take another 10, 15 years probably, but it will happen.
We have to change the educational system because we don't have, at least in Boston, we don't have any basics on
Yeah.
programming, grammatical stuff like that.
No,
Probably used in those.
absolutely. Absolutely.
There are programs that education of doctors and healthcare practitioners or like a basis of
And you know, there is the people who say, nah, robots and old people, that doesn't come together, you know. They don't like these artificial, they want people with a warm heart and blah, blah. That's completely wrong, you know. These old people, they are just happy about these robots because they are there, you know. What is a warm heart with a caring nurse worth when she's not there or when we don't have them? So the availability is a very important and strong factor for the elderly. So we shouldn't be too safe about our positions in the system. So let's do good work. That's helpful. Yeah, that's how FDA approves AI algorithms. That's not anything you need to know. I just want to show you that there's already AI approval systems in place. And these AIs, you know, there is the data selection and there is the training, and then there's the deployed model that gets out of it, and there is always further training. But that also implies that these models get access to data, and it's absolutely not clear so far why should you give your data away for nothing? You know, you could say, I give you some data, but you know, $30,000 and you're in. And if somebody bids more, I'm happy. You know, if you like train a student, if you have a student, you give this student advice in mathematics or so, you charge for that, of course. But you don't charge for your data. You just give them away in social networks, and healthcare data is probably the most important data that we have. So we should make up our minds on how we deal with that. Should we just give them away to industry so that they can make tons of money and put in AIs in place that then learn and learn and learn again and get better and better to make them more money? So the question is really in the future, where is the patient in this loop? Because nobody talks about the patient. Yeah, there is algorithms in diabetic retinopathy, there is in ROP, there's lots and lots of AIs that are already approved and in place. So make sure that these things will come. They are already out there.